interesting that I ran into one of my patients today. Here I was walking, as I was walking in, and I think she can vouch for me. I love interacting with my patients. New patient visits are very, very interesting for me. I get to learn about them, what their concerns are, what their fears are, and I think I can make a connection with my patients, and that's very important to me as a rheumatologist because most of my patients come with diseases that's gonna stay with them. So it is a lot of what I share with them and how I interact with them and the like strength and bond I make with my patients. I can be their cheerleader and I can back them up as they learn to take control of their disease. So today I've been invited to talk about some specific points, and I have some slides on the background here. I'm not gonna focus much on what's in the slides. We're mostly going to talk, and I think we have about 15 minutes later for questions, I believe. Okay. So some topics that I would like to touch upon today, mainly treatment compliance, lupus and vaccines, and the role of participation in studies for lupus. Okay, you're gonna do that for me. Okay. So medication in lupus. Just going to start with a little bit of a scenario. I had a very young patient the other day in her 30s, and she had some abnormal antibodies in the blood that her family doctor said, you may have lupus. And she lost sleep until the time she was able to see me. I don't know how many days it was. I could tell she was very anxious when I walked into the room. And I ask a lot of questions when I first see my patients, just to get to know them. And as I said, how many children do you have? How old is your youngest? She burst into tears. And for a second, I was confused. Like, did I insult her in a way? Should I have not said that? And then she said, there are two members in my family with lupus, my brother, my sister. I fear for my children. I'm going to die. They're not doing so well. And I kind of had to take a moment to think about what she said. How did the diagnosis of lupus become a death sentence for my patient? She's 38. She's the sole breadwinner for that family. So I sat there and I tried to reassure her as much as I could. But I have time limitations. I cannot do more. But then I tried to tell her, this is not lupus right now. We still have so much more to investigate. Either way, even in the scenario that you do have lupus, I'm here for you. We have so many options. This has been one of the most vigorously investigated and studied diseases since it was first found out in about the 1800s. We have so many options. We have so many resources. And we're going to discover them as we go forward. This is just the first visit. But I do not want you to succumb to this diagnosis. There are ways to fight it, and we're going to find ways on how you can be active, fully functional, and still have a life with the disease. So as I start with that, patients have fear of the disease itself, fear of the medications, and we always fear what we don't know, right? So I always encourage my patients to say, ask questions, write it down if it's helpful for you. And when I say do that, I don't mean 5 to 6 pages of typed out questions, and have a little bit of mercy on me too. But, just think about the things you want to ask me. So common medications in lupus. I want to ask, which is the most widely heard of medication in terms of lupus treatment that you all may have heard of or used at some point? Anybody? Plaquenil, right? There are so many fears about Plaquenil. Um, it's a very, very good medication. And I say that because, number one, a lot of our patients are young in the reproductive age group. So it's a safe medication to be on. You can continue it throughout pregnancy without interruptions. One of the only medications in lupus that has been shown to protect or protect against development of lupus nephritis, which is one of the major causes of mortality and morbidity. And do you think I might be able to advance the slides also? Yeah. and it's very effective, mainly when we're talking about like skin manifestations, which is in a lot of our patients. And like I said, it's a medicine that can be started on, very well tolerated, no, usually very minimal side effects. But whenever I mention the word Plaquenil, all of my patients are concerned about side effects, which is the eye manifestations. They ask me, what about blindness? One of my patients came to me, I started her on Plaquenil, and then she came back and she said, I cannot take this medication anymore. She was a Hispanic patient, and all this time, using the translator, I was trying to tell her that her blurring vision is not likely from Plaquenil. Just imagine the, break in communication there. The patient is already anxious, and I'm having to like explain things to her um, by using an interpreter. But I think that's one of the reasons why there's so much fear about the medication. And every time I talk to my patients, I try to eliminate this fear in them. And you can only overcome that, your concerns, your fears, or know about your side effects, if you establish, first of all, establish medical visits, continue for your follow-ups, and ask questions, and maintain a relationship with your provider. You can take help of all the resources you have, um, go to the right kind of websites to look for answers, and that's most important. Don't Let's not try to be overcome with the fear about a medication without knowing the specifics of it. When we say a certain drug has a certain side effect, there are lots of nuances to it. First of all, the dose that you're taking. Second of all, the duration that you've been taking it for. So there's a lot of factors that take place. Okay. So what to expect with hydroxychloroquine? When we start the medication, it's usually a very slow onset medicine, which is also one of the reasons patients say it's not really working for me. They have complaints about fatigue, joint pain, and it may take anywhere from 6 to 12 weeks to work. So we have to give it some time. Um, because there have been studies that have shown that when you take hydroxychloroquine in a significantly high dose for an average of, let's say, the median timeline is after 7.5 years. If you're taking a cumulatively high dose, there have been some cases of retinal toxicity, but because it's an important organ of the body, even if it's very few cases, we do monitor for it. That's why it's important to do a baseline exam when you get started on the medication. The baseline is just to see, is there any prior changes in your retina, which is the like backmost layer of your eye. People have diabetes. People have other diseases that can also cause some damages to the retina. So when we first start the medication, we want to make sure there's a clean sheet, because next time when we monitor or we look at the eyes, we want to make sure that that is not from the hydroxychloroquine. So we say, go for your eye exams. And then what do? We don't need anything for 5 years. After 5 years, we do it every year, because the longer you use it, your risk increases a little bit. The best part about hydroxychloroquine or Plaquenil, you don't really need to interrupt it for vaccinations, which is a little bit different for other immunosuppressant medications. Um, the blood work is very less. There's no specific guidelines on hydroxychloroquine and how often you do the blood work just for that or what organs to monitor. Um, there have been few reports of when people use high dose Plaquenil for long periods of time, um, that it drops your blood levels a little bit, but it's a very, very rare side effect, and we don't really monitor for it. But once or twice a year, if you do your blood work just to monitor blood counts, that's adequate. And like I mentioned earlier, the side effect profile is very less. these days, they are coming up with checking blood levels for Plaquenil, which is also a great step that's coming. They're already starting to use it at places like Johns Hopkins Lupus Center because they have, I think, at least 2,000 patients that they see. So they are trying to use that. And that is another good thing because that way we will just give the patient a dose that is just about right to give you benefit. So we don't need to, we know how much the blood level is. If it's too high, we can reduce the dose. Welcome. We were just talking about hydroxychloroquine or Plaquenil. So when you check the level of a drug, you know how much your body needs. If it's too high, we can reduce the dose. If it's too low, we can boost it up. But it's another quicker and better and more effective way of saying, are you getting more dosage of Plaquenil than you need? So you know what you need and you can titrate it. But as far as I know, this is not widely available yet. At Metro Health Hospital where I work, we can check the levels, but it's usually a send out test. So it takes about a week or 10 days to come back. And I don't think it's fully covered by insurance yet. So it's not something that we can use at our routine visit. Thank you. I'm going to put you busy too. So another medication that we use very, very often, a lot of my patients have a hard time getting off of this, glucocorticoids, prednisone, methylprednisone. What are they? They're basically physiological hormones, but very potent anti-inflammatory agents. I like to call these the double-edged sword. In most cases for our lupus, it's life-saving. When you have a bad flare, your kidneys are inflamed, or in very rare cases when patients have lupus cerebritis, they end up in the hospital comatose. They don't, not reactive, they're not mentating well. And you give them high dose of steroids and the inflammation is calmed and they're okay a day later. It's miraculous. But when used long term, the side effects are innumerable. Dr. Petrie, the physician I was mentioning to you about, there was a study done at Johns Hopkins with their lupus cohort of patients over the past few years. And a paper was recently published that said, in the past we used to say, as long as you're like at around 5 milligrams of prednisone per day, it's safer. But that's changing. Their outcome was even prednisone in the doses of 2 to 3 milligrams are associated with some kind of side effects, whether it's cardiovascular or things like that. So we need to be clever about how we are using prednisone. I try to tell my patients all the time, this is not an everyday drug. It's a bridge. When you're flaring, you use prednisone, but you have to be on an immunosuppressant. If you're flaring that much, prednisone is not going to do the trick. When you're on high dosage of prednisone, your body becomes dependent on it because it acts like a physiological hormone. So your body and the organs that are supposed to produce it becomes lazy. So it just relies on the drug. And that's very important. People who are on prednisone doses more than 7.5 for more than 3 to 4 weeks, if you stop the drug without tapering it, then you go into a withdrawal or a collapse. And these are hormones that are essential for life. So these drugs should not be taken lightly. This is not a cure for, most people with lupus, they struggle because there's a lot of ongoing chronic pain. There's a lot of arthritic pain. And prednisone does miraculously. But that should always be smallest dose and for the shortest duration. It is a very good drug. But what I want to emphasize is we have to take control over how much drug we use and how long to use it for. We always need to be aware of the side effects. All of my younger patients who are on prednisone for a long, long time, we have to screen them for, um, we have to check their bone density scans to screen them for osteoporosis because doses more than 7.5, you're at high risk. The good thing about prednisone, it's affordable. We don't have to, excuse me, do prior authorizations with insurance. The dosing can be split. It can be once or twice a day, and like the dose can be taken in. It can be like manipulated to suit your symptoms every day. So it's an easier dosing, unlike other medications who you cannot play around like that. And like I mentioned earlier, it's a very good agent for uh, severe conditions. So goal for steroids always smallest dose, shortest duration. It's a bridging agent, not an everyday medication. When you use it for long term, we always need to taper it. We cannot stop using it just like that. And long term use has been associated with low bone densities, atypical fractures. That's something we need to worry about. And so if you find yourself that you've been taking prednisone for a long, long time, it may be the time to ask your doctor, do I need to get screened for low bone density or osteoporosis? Um, so whenever we talk about medications, it's overwhelming to have a new diagnosis, especially overwhelming when you're popping 3 or 4 pills that you don't know about. And that creates issues for compliance. What are the common factors that are contributing to non-compliance, I would say? Side effects, cost of the medications, especially the newer agents that we use, unless your insurance is covering for it, they are very cost limiting. Lack of knowledge about available resources, because if I feel like I'm alone, I've been diagnosed with a disease I don't know about. My doctor tells me to take 5 medications that it's essential for me to be alive. I'm going to be overwhelmed. So far, I've been on the opposite side. I sit with my patients and I say, you need this. This is good for you. Research has shown that. But I haven't been in that position, right? But I think I'm an empathetic person, first of all, before I am a physician. So I try my best to put myself in that place and say, how would I feel? So for me, my approach is always, let's start with one small thing. Let's talk. Let's see how you do. And then we'll take the next step. With rheumatology, there are not always clear answers. A lot of my patients come to me and I cannot tell you today if you have lupus or not. Things are very complex. But we all have to learn to be patient together and follow the course. In the meantime, we'll get answers and we'll know how to deal with it. I guess I can call it lucky or unlucky in a way. The man I got married to also has autoimmune disease. So now I have 2 roles in this to be involved as a patient and as a patient advocate for my husband, who's very careless, I have to tell you. And I have to act as his doctor all the time. I just don't get paid for it, which is very unfortunate. But yeah, knowing your resources is very, very important, especially in this day and age, because everything is available on the internet. But you always have to take that with a pinch of salt. Be important what resources you are going to. Because if you read the wrong things, it's going to definitely cause more anxiety. And like I said, medication and side effects are something that you have to critically analyze based on how your body is doing, what dose you are taking, how long you are taking it for. And that's similar with interactions too. So don't read something on Google and then worry about it. If you have questions, ask your doctor. It can be your family doctor, your rheumatologist. And it's very important. Find a doctor you like. You know, just because I say I care about my patients, I'm very involved in this, does not mean you have to like me. That was my first successful joke today. We're all different, right? So we all click with somebody, we don't click with somebody, and that's okay. I always ask my patients when I see them, it's up to you if you want to see me again next time or not. And it's completely fair to do that because this is a journey. You need to find somebody whose hand you can hold and walk for years. Okay? So you have to make that decision yourself. Um, so when I go back to compliance again, I think how you dose a medication also makes a huge difference. If there's a medication which I can take once a day, don't have to wake up in the morning on empty stomach to take, just once a day, anytime I want. I don't have to take it 4 or 5 pills. Compare that to something that I have to inject every day. It's a lot easier to take a pill, right? So all of the different kinds of routes and doses you take makes a difference. It's more stressful to take something that you're going to forget or going to cause you pain. So there should always be an ongoing, I would say, search to find the most easy enough medication for you to make it sustainable. And that should also be the goal. There's something where we say, oh, this is the best agent research has shown. But you also need to compare, is this affordable for me? Is it something that I can take every day without feeling like my life is going to be over? Is it something that I can tolerate? So we have to compare and contrast all these factors and have a discussion with your physician. Vaccines. Um, Now, if I'm talking more than I should, somebody can cut me off and say I'm going over the time because I think I'm limited. Okay, thank you. So, vaccines. Why do we stress about vaccines so much? Because what is lupus? It is a disease that primarily messes up with your immune system. We've all heard about B cells at some point. We have T cells and B cells in the body. These are all white cells that fight infections, viruses, bacteria. B cells primarily make immunoglobulins. Those are the primary defense in your body. And research has shown overall that patients with lupus, their B cell functionality is abnormal. So you're already limited in your ability to fight diseases. On top of that, the medications we use, we like to call them immunosuppressants, and they can range in their ability to how strongly they can suppress the immune system, but at some point, all of them do. So when you combine it all together, you're more prone to getting infections than the general population, and thus the stress on vaccines. Because if you get an infection, your immune system is going to go crazy. And mind you, this is already a bad immune system because it's already attacking your healthy organs from baseline and now mix that with an infection that it's trying to fight. So it's like a vicious cycle. And we don't want that to happen because it's going to do more harm than good. That's why we want to hit it when we can hit it early on. And that's prevention. Prevention is always better than cure. And I cannot stress this enough. I find that it's my failure when I cannot get my patients to be vaccinated. That it's very, very important. So no vaccine is 100% effective. But I would like to say even a partial protection is always better than no protection. Some vaccines, you can test the auto antibody levels and say you have protection. Like we check for like the MMR vaccines or when you do like DPTs or other things, we can check for the levels. But some vaccines like the flu vaccines, we can't check antibody levels and say, oh, you're protected. That's why we stress so much and say, oh, this is flu season. Get vaccinated, flu season. I think at some point we're going to have that with COVID as well. We're not sure yet, but we need to keep our records, make sure we're vaccinated. There can be different types of vaccinations, dead or inactivated vaccines, and live vaccines, live attenuated vaccines. So they all create a different kind of trigger to your body. and there are different live and attenuated vaccines that you need to take, but they interact differently with your medications and your disease state. So there are certain recommendations on what vaccines you should take, you need to take, and how to hold your medications around that vaccination time. So where to look for these answers? CDC. We've all heard of CDC. They've been famous and infamous during the COVID era, but they are always a good resource to go to when we look for vaccine recommendations. They can also give you recommendation based on when you need to travel. They have travel guidelines, infections guidelines, everything. We all usually, I think our Bible is the American College of Rheumatology. Group of experts every year come up with recommendations. And what we always have to remember is medicine is ever revolving, updating. What was true 3 years ago may not be necessarily true now. That doesn't mean they're doing the wrong things. Research is always undergoing. We always find new targets, new strengths to something. So we have to follow it too. This is not like other things which once we read it, it stays forever true. So keep checking for those. American College of Rheumatology recently, in January 2023, published its updated vaccine guidelines for patients with rheumatological diseases. So I think that's easily available over the internet as well to access. I've also added a link here, which can be shared if needed, but that's somewhere you can look for recommendations. Lupus Foundation. I like to check their websites from time to time. It's very user-friendly. There's lots of options and answers you can look for in there. It's a very handy website to share. Ask your family physician. They have a lot of knowledge regarding immunizations too because they do that for a living. Your favorite rheumatologist and infectious disease specialist. Sometimes there are certain scenarios or conditions that start to become a little bit complicated. There are sometimes infections like TB, or you have certain infections which tend to impact with your medications or things like that, or when it's like travel related, or when there's like concurrent HIV. So those are things where usually infectious disease specialists also can help us regarding vaccinations, medications, and things like that. So if you're already following with one, then that's good. That's your also go-to person. Lupus and COVID-19. I think I've stressed this enough so far, and we all have. The ACR recommends that patients with lupus and other autoimmune diseases all should receive the covalent vaccine, COVID-19 vaccine, and now the bivalent vaccines. So this is the updated ACR guideline that I pulled up. It doesn't look very pretty, but basically what it says is all patients over the age of 65 and patients with rheumatological disorders above 18 and less than 65 should be getting the influenza vaccination. That's the flu vaccine. Anybody aged than 65 on immunosuppressive medications should be getting the pneumococcal vaccine. And when we say immunosuppressed, even steroids after a certain dose come under the topic immunosuppressant. So if you're taking steroids more than 10 or 20 milligrams a day, then you fall under that category. If you're over the age of 18 and you're on immunosuppressive medications, you need to get a zoster vaccine, which is a chickenpox vaccine. And age over 26 and less than 45, also on immunosuppressives, not previously vaccinated, need to get vaccines for HPV. That's a conditional recommendation, so it can be discussed with your physician or your rheumatologist. But that's also something that can be protective because we need the HPV vaccine to prevent against cervical cancer. We're not going to go too deep at this. This can be found at the website as well. I just wanted to highlight that common medications like methotrexate, rituximab, they need to be either held before or after vaccinations when you're talking about non-live attenuated vaccines. So methotrexate needs to be held for 2 weeks after. Medications like rituximab, they are one of the strongest immunosuppressive medications when we talk about B-cell immunosuppression. So those, when we're talking about non-live attenuated vaccines, you need to hold it 2 weeks after vaccinations, or the vaccine needs to be given in a way where it's like closer towards the next dose of Rituxan. But that's more important for live attenuated vaccines over non-live attenuated. And anything like Paconil can be continued without any changes. So this is guidelines on what to do about prednisone. So if it's prednisone, the colors, the darker the green it is, the stronger the recommendation. So even when they give guidelines, they say this is strongly recommended, this is conditionally recommended, just to make our jobs harder. All of the conditional recommendation is they're just saying just make up your own mind. There are things you need to discuss with your patients and take their special circumstances into consideration. But stronger recommendations we follow. Any prednisone less than 10 or equal to 10, influenza vaccine or flu vaccine can be given without hesitation. Anything more than 20, flu vaccine is okay, but other non-live attenuated vaccines, you may need to defer it or discuss it with your physician. So the whole summary of this slide is if you're on larger doses of prednisone, over 20, you need to discuss that with your physician about getting vaccinations. Overall, vaccines play an important role in lupus patients by preventing infections. That's the whole summary of it. Most vaccines are safe. Flu vaccines, pneumonia, zoster. And most ideal when your lupus is quiet or in remission. So study participation, and I cannot stress this enough. Why so much emphasis on study participation? All of the humongous trials, whenever we say trial, it's usually phase 3 trials. That's involving more than 100 patients in the trial. These are done to check the effects of a drug. And I think we have more people that are going to talk about medications and trials later too. But whenever we do these trials, what we're looking for is the effect of the medication and side effects. The larger the study population, it can be studied more widely, and it gives a certain thing called validity to the trial or the test. If you study something in a small group like 5 people, the study participants are non-diverse, can you go and apply that to a huge group of people with different diverse population? Most likely no, right? So far, all of the studies that have been done, it's been very undiverse population. Most of the study participations, over 60 to 70%, are white patients. About 10 to 20, or let's say 30%, are African American, and a very tiny population Hispanic. I'm from Southeast Asia. I've never seen a single patient from Nepal or Southeast Asia be a part of these trials. So we don't even know the impact of lupus or these medications, how it's going to affect these patients. We are also different geographically. Our DNA is different. The effect, the climate, the elevations above sea level, all of that can cause a difference. So how can I truly close my eyes and tell, like you as a patient should think, how can I truly close my eyes and say, this has been widely studied in a patient exactly like me? But when we say, let's take ownership of the disease, it is also our responsibility to engage. We need to create that opportunity. Unless we cross that line and say, I want to actively participate in this trial because I need to know how this medication can impact me and patients like me, going to be no change. So we need to be our own advocates. That's why we need to participate, because we need to know. So far, all of these treatments that have been possible for lupus have been possible just because of these participations. The armamentarium of the tools and treatments that we have been possible because of research. It's an ongoing research. There are more study researches that's going to happen over the next 5 to 10 years, but we need to engage. We need to increase our participation. Also, patients with African American and Hispanic races have had, compared to white population, poor outcomes in terms of lupus nephritis. They're more high risk. And those things can be missed when we're talking about these medications. That's also something I need to stress upon. That's why participation is more important from that realm as well, because we need to know the impact of these medications in curing or treating those conditions. As I grow closer to the end of my slides, the most emphasis I want to make on is taking responsibility. We need to take responsibility of our own disease. Use the resources that you can to learn about your disease. Like I always say, we fear most what we don't know. How do we change that? We learn. It's a process. Don't overwhelm yourself by saying, I don't know what this is. I'm never going to know enough. In this day and age, we should not be creating excuses. Let's reach out as much as we can to learn about it. And I think we're lucky in a way. We have so much resources. Look at how much Lupus Foundation is doing. They're always there. Community support is there. Physicians are there. Hospitals are there. Websites are there. Let's try to get the right information and let's fight this together. Ask questions as much as you can. Be regular with your visits. Type down your questions, scribble them. Don't be afraid to ask questions. You have nothing to lose. Ask as many questions as you can. Communicate and educate those around you. It's like passing the baton or something, like the relay races we used to do as kids. If you find something that's helpful for you, spread the word. We want to make this as strong as possible, as globally prevalent as possible, the information, not the disease. You have to put yourself in a place where you can make all of your own decisions regarding your treatment. But when you don't have information, you cannot do that. That's why I stress upon all of the questions and the information. You need to feel like I made this decision in an informed state. I asked all the questions. I'm satisfied about where I am, and I would like to pick this treatment. Because the attitude you have when you start a medication plays a humongous role. Any treatment that you take with a negative attitude does more harm than good. A positive attitude is very, very important. And that comes only when you ask the right questions and when you have the right resources. Let's all encourage in participating in trials. Spread the word. There's always trials ongoing. There's a website called, I completely blanked out on the link, but I can share that with you later. But there's ongoing trials that are happening. There are websites that can show you the trials that are happening just for lupus itself. So you can use those resources as well if you're interested to participate. And let's all join hands together and create a circle of help and hope. So my final agenda for today is, let's learn to take control of lupus and not let lupus take control of us. Let's dominate this disease and let us have dominance over it for the rest of our lives. Thank you.